Hello and welcome back to the channel. My name's Dr. James Gill and join me for another clinical skills video. Today we're going to be talking about the knee, which Bob has kindly donated from next door. And in terms of the knee, it's actually quite a fascinating joint, and we're hoping that with the anatomy we're going to hopefully impart some of my love for this joint to yourselves at home. Now, the knee is the largest joint in the body, followed shortly afterwards by the hip and the ankle. Now, whilst we're going to focus almost exclusively to the knee today, it is important that we highlight the hip and the ankle with regard to knee pathologies, because pain to the ankle, or the hip for that matter, can cause radiation. So we may be getting pain at the knee that is not actually related to the knee joint itself, but coming from the others. Now, the knee provides, a bread and butter work for orthopaedic surgeons, and that's largely because these joints can become damaged with age and can end up being replaced. But, as we'll talk about shortly, the knee shouldn't wear over time just due to the passage of the years. But if we have imbalances to the knee, we can get changes in the forces passing through it that can result in some problems. So, on to the knee. This is probably my favourite anatomical joint, and yes, you can have such a thing. I think there's something about the interplay between the bones and the ligaments and the tissues where we're going to get the bursae and the muscles interjecting into the bones here, and just how everything functions together to give a smooth biomechanical joint. It really is quite elegant, even to the structures inside the joint, the menisci and the internal ligaments, allowing small degrees of movement to allow that fluidity of movement. I think it's absolutely fascinating. And with regard to that, we're going to start off with the very basics, the bones of the knee. Now, there are three bones that make up the knee. We've got the femur, we've got the tibia, and we've got inside the knee the patella. Now, it's very important that we highlight the fibula that we can see on the side of the leg laterally is not part of the knee. It has a small function in terms of the roles of some of the ligament attachments, but it should not be considered to be part of the knee. There are only three bones in that joint. So before we go any further, I just want to cover a little bit of vocabulary. When we're talking about the knee, and this is a right-sided knee, we need to have two words in our mind, and that being medial, so the inside of the knee, and lateral, that being the outside of the knee. And an easy way to tell that when you're looking at a patient is, whilst we've said the fibula is not part of the knee joint, it's a really useful landmark because the fibula is on the lateral side of the knee. So with that in mind, let's have a walk around the knee. So when it comes to looking at the knee, we've got the femur, which is the largest bone in the body. We're going to ignore the distal section for the moment and just focus on the proximal, where we're dealing with the knee. So if we remove the patella for a second, we can see that there are these large swellings at the base of the femur on its distal aspect, and this is where we've got the hyaline or articular cartilage covering two rounded protuberances, and these are the femoral condyles. Now, if I move that round to here, we can sort of see this round smoothness here. And that relates to the name of these condyles. So condyle comes from the Latin for knuckle. And I think we can just about see where they're getting that from. We've also got the patella in the patellar tendon as the second bone of the knee. And below that, we've got the tibia onto which everything is going to articulate. So staying with the Latin for a moment, we've also got two enlarged areas above the condyles. Now, we can see how these are named. These are named the Epicondyles because epi from the Latin above, and condyle, as we've seen, is this knuckle-shaped protuberance. So it would make sense that these further swellings are the epicondyles, as these regions are above the condyles. Now, when it comes to the condyles, they are so very enlarged because of the forces that pass through our knees. They need to be able to take the huge weight of the body, exacerbated by the impact forces when we're walking and when we're running. And by having this significant girth to the bones here, it allows them to have a large area for cartilage and shock absorbers for the menisci to enable smooth movement of the knee, so we don't get any damage over the lifetime of the joint. So when it comes to movements of the knee, we've got flexion, where we take the knee out of alignment. We've got extension, where it's brought into, and perhaps even over extension. We're also going to have a small degree of rotation as the knee can slip across the meniscal coverings of the condylar surfaces. And that's a crucial, that movement is rotationally is very, very important to making sure that we're optimizing our movement and keeping everything safe within the knee. Now, whilst we say that the knee and the hip are the bread and butter of the orthopaedic wards, it's important that we highlight that whilst we can replace the knee, it's never going to be as good as the one you have. And one of the crucial things that we lack in terms of artificial joints is this hyaline or condylar cartilage. This cartilage, again, allows for the smooth movement of the knee, but with all of our technology, we haven't managed to create something that has such a low friction coefficient, which is why artificial joints tend to have a limited lifespan. They will wear out over time. Now, at this point, it's very important that I highlight that your knee should not wear out. There are people who will unfortunately have pathology of the knee that will mean there is a disruption to the forces going through them, and that is going to result in problems with the knee. But as long as you use your knee as it's evolved, as it's designed, it should easily last you a lifetime. I mean, look at it. I mean, it's designed for running on. As we said, we've got the epicondyles, where the ligaments are attaching. We've got this huge expanse of cartilage over the femoral and tibial condyles. And between, we've got this wedge of meniscus that allows to work as both shock absorber and helps us to move the knee in a rotational component, ensuring that we can absorb and also be more efficient in our standing. But whilst we've got all this shock absorber present for the knee in the anatomical position, as it were, look at the patella and around it. Yes, we've got some bursa that fill in these holes here, but the knee is not designed for you to be spending years and years kneeling on, pressing down over. This is going to cause damage and wear and tear over time because it's not how the knee has evolved to function. And we see that with people. We rarely get wear and tear from straightforward use of the knee. If there is any problems, it's normally related to the biomechanics, where something like the patella is pulling off ever so slightly to the side. It's not because we're overusing the knee. It's the biomechanics have changed things. So, for example, if we've got damage to the meniscus, that's going to mean our shock absorber is less effective and we get more friction here. Going back to the point about kneeling down, if we use the knee in a way it's not evolved to handle, we are going to get unexpected wear, we are going to get unexpected damage over time. So the patella is moving in the space between the femoral condyles in the trochlear groove here. And we can see that nice smooth movement here. But if you're kneeling down on the patella over time, that can cause wear and tear to this cartilage and similarly cause problems in that groove, so that you get sticking and discomfort here, increasing pain around this area and increasing the likelihood of wear and tear and osteoarthritis. And we often see that in people who've been kneeling down in their careers, rubbing the patella against the femoral condyles here. And this is how we result in wear and tear of the knee, not from overuse of the knee, but for inappropriate use. And the vast majority of early knee and joint pain is often biomechanics. It's a problem with the ligament, it's a problem with the menisci, it's a problem with the muscles. And often brief assistance from the physiotherapist can often put you back in alignment, and meaning that you're going to have good distribution of forces, and that should remove the pain there. It's only over the long term, if these abnormal forces haven't been adjusted, that we will then get that wear and tear. Just to reiterate on that, your knee wants to be used. The Highline cartilage that we have here wants to be compressed. It wants to be filled and surrounded by the synovial fluid. Walking, exercise, jogging even, is good for your knee. It's good for the cartilage. Whereas being inactive, sitting down all day, not exercising, not getting the movement and the compression of this cartilage is going to cause it to not wear out, but it certainly won't be as healthy as it is in a nice, mobile, used joint. Again, I go back to the fact that it's when it's inappropriately used, such as long-term kneeling, that's where we get our problems. So in terms of there not being any shock absorbers and things over the patella, let's actually just have a look at the patella for a second. So in terms of the patella, it's what's referred to as a sesamoid bone. So a bone that is held entirely within a tendon. And in terms of the front, we can see some interesting things about the patella. So a tendon connects muscles to bone. So very much coming from the quadriceps to the patella, we've got the patella tendon. Now a ligament connects bone to bone. So technically, with the patella being a sesamoid bone, from the patella to the tibial tuberosity is technically the patella tendon. However, if you look at this ligament histologically, you'll see it contains the same tissue fibres and structures as we find in a tendon. So we do describe the whole piece here as the patella tendon, but it's not incorrect to describe this part as the patella ligament, but I think that's more of a bizarre facet of anatomical nomenclature rather than true biology. And the purpose of the patella here is to stop wear and tear at the patella tendon. So we've got a huge amount of force exerted from the quads in order to straighten the knee. So that force has to come down the patella tendon here. And if this cartilage covered bone, the patella, wasn't here, then that would be putting a lot of strain on the patella, giving a much greater probability of that patella rupturing. And as soon as that ruptures, as you can see here, the knee cannot extend, which is why when we're assessing the knee, we'll get the patient to hold their knee in extension, because we know that the patella is intact. But to reiterate that, as soon as it goes, the knee will lose our extension. And we can see that sometimes when somebody goes to the gym. They're putting extreme forces through the quadriceps tendon, through the patella, and into the tibial tuberosity. And thus we can get an avulsion at the tibial tuberosity where it rips off. We can get rips to the quadriceps muscle, meaning the tendon comes off at the top. And we can also get damage to the patella tendon, again where that can rip, all of which can result in the loss of that extension, and often quite dramatically so in those situations. So having talked about the femur and the patella, we probably need to come down to talk about the tibia as well. In terms of the tibial plateau, we've got this large flat area of bone where the tibia is flowing out proximally with a protuberance at the front. Again, this area is the tibial condyles, but I don't know about you, but it doesn't half look like knuckles as much as the femoral condyles do. On the front, we've got the tibial tuberosity onto where the patella will insert. And we do have a point of articulation with the fibula head, but we are highlighting once again the fibula is not part of the knee joint. So if we pull the femur out of the way, we can see how the tibia here is scoop shaped. You know, it's concave, unlike the convexity of the femoral condyles. And this means that we've got a wonderful area for those femoral condyles to articulate, held within these cups that are exacerbated structurally and physically by the menisci here. On the front of the tibia, below the condyles, we've got the tibialtuberosity, and this is the insertion for the patella. So as we mentioned, if there's a problem with the patella and we get a rupture, we lose the ability to extend the tibia. But we can also get damage here of the tibialtuberosity, whether or not it's a straightforward blow, or whether or not it's a more progressive issue that can A, impact on the patellar tendon, but also impact on the ability to extend the knee. So there's a condition that affects the tibial tuberosity here in adolescence called Osgood-Schlatter's. We get inflammation at this point and microavulsions due to repeated traction as the patient is growing. And in some patients that can be incredibly painful every time they straighten out the knee, because all of the force is going through this inflamed, sore and slightly damaged piece of bone. And unfortunately, the main treatment for that is going to be rest, ice and compression there. With that, we tend to see it most commonly in patients that are very active in their adolescence, but we can still see it in students and patients that are not particularly active. So it's not absolute on that side, but we do know it seems to be related to the forces passing through this insertion point. So, having covered the bone above and the bone below, we probably need to finally get to that inside of the knee. And this is where the menisci sit. So the menisci are two C-shaped areas of tissue. And this is fibrocartilaginous tissue. It's quite robust and it's got much more movement than the condylar cartilage of the femur and the tibia. And as you can see here, there's a slight raised outer edge of both of these C's, and that has the purpose of A, working as a shock absorber, and B, helping to increase the cupping at the tibial condyles, meaning you've got increased stability of the knee. And stability, that's a crucial word for the knee, because everything in the knee is working towards stability, whether or not it's the massive quadriceps, whether it's the ligaments to the side, whether it's the shaping of the menisci or the ligaments within the knee. It's all about promoting stability of this joint. And that relates to what I said right at the beginning. It's changes in the biomechanics, changes in the throughput of forces through this joint, problems with stability, for example, that will result in wear and tear over time. If you've got good biomechanics, good stability, you're not going to get wear to your joint just by using it. So crucially, stability of the knee is very important, hence the menisci shape, where we've got a much steeper curve on the outside compared to a thinner area on the middle. This stability is aided as the menisci can move slightly within the joint, as highlighted by the transverse ligament. In fact, this movement helps the health of the knee. When you stand straight, your knee medially rotates ever so slightly, rotating toward the midline, and this allows you to anchor your legs slightly more firmly on the tibial plateau and gives more stability and means that you actually use less energy when you're standing. But this movement isn't without cost. We can get small tears that can mean the knee can lock onto the menisci if that tear causes it to fold over and jam. So you'd need to take the patient to theatre in order to trim off that tear and try and return the menisci to its position so it's not allowing locking. But as we've said, if we trim part of this menisci, we are going to result in instability of the knee. So again, going to have increased risk of wear and tear over time. Now, in terms of that movement, on the front of in terms of that movement, on the front of the menisci, we've got a ligament that helps to anchor the front part of the menisci. And this is like a guide rope on a trampoline. It does allow some stretch and a little bit of movement, but mainly keeps the trampoline, or the meniscus here in this case, fixed in position, which makes sense. We want a little bit of movement when the forces come down, ensuring we've got good support and good capturing of those forces, but we don't want excess movement of the menisci because that's going to cause significant problems. In terms of damage to the menisci, we tend to get that with a forced injury where the knee turns but the foot remains flexed, and we can see here how that femoral condyle can munch on that menisci if we get an excess turning force. So that's often seen if the leg is fixed in the ground and the upper body twists. For example, somebody who is playing football and the studs had them anchored at that time. So we've said that the menisci helps stabilise the joint and the transverse ligament helps anchor the menisci here. But there's 4 other structures, the ligaments around the knee, that help to increase that stabilisation of the joint, along with the muscles as well. We've got 2 on the outside, the lateral and medial collateral. Now, it's worthwhile highlighting at this point that the lateral collateral is a true ligament. You can easily see the start, the finish, and it's nice to find borders. By comparison, the medial collateral is a lot broader because it's less of a true anatomical ligament and more of a physiological ligament formed from the blending of the muscles on the leg. So the lateral collateral is injured with a blow from the inside of the knee. So for example, the blow comes in and bends the knee out, resulting in a tear here to this ligament. The converse is true for the medial collateral. The blow comes in from the lateral side, the outside of the knee, resulting in a huge stretch here where we're not wanting it, resulting in its rupture. Now, once these are gone, again, we're going to get much more movement than we'd expect, which will allow degeneration of the joint. So we want to try and keep these contained and intact, well, for our lifetime. But they're not as important as the cruciate ligaments. These are directly inside the knee, and if you have damage with these, well, your knee will never be the same again. So these are beautifully named ligaments, the anterior cruciate ligament and the posterior cruciate ligament. Now these are so named because, as we can see in here, they cross over, hence the Latin cruciate. And their names are easy. The anterior ligament stops the knee moving anteriorly, and the posterior ligament stops the knee moving posteriorly. And similarly, the anatomy guys clearly name these things beautifully because the anterior ligament shows where we're anchoring into the tibia. So the anterior cruciate ligament is going from the posterior of the femur into the anterior of the tibia. And at the back, the posterior cruciate ligament is going from the anterior of the knee into the posterior of the tibia. The anatomists who named these really had their thinking caps on when they came up with these names. And I do think there is a significant degree of elegance to it this way. Now, the anterior cruciate ligament is one ligament in its own right, whereas the posterior cruciate ligament has this second meniscal femoral component that acts as a sort of a bit of a backup coming from the menisci there. So even if the true PCL goes, you've hopefully got a degree of a backup there. And I can't underline this enough, how important the ligaments are to the stability of the joint and thus the protection of the joint. If one of these goes, even if the surgeons are able to repair it, we need to make sure that we strenuously engage with physiotherapy to strengthen the other muscles around the joint in order to provide the maximum support that we can. So we've talked over the femur, we've talked over the tibia, we've talked over the patella, our sesamoid bone, and covered the menisci within and the anterior and posterior cruciate ligaments, as well as the lateral and medial collateral ligaments. So that's a good overview of our knee. Hopefully this has been useful to yourselves. We've only really talked about Osgood Slatters as a pathology here, but certainly drop comments down below if you'd like us to delve a little bit deeper into some of the other pathologies that we can get with the knee. If you'd be able to like the video, I'd be so grateful because it tells YouTube we're here. And if you found that these have been useful, please consider subscribing and you'll get a notification for when we're doing the next video. With that in mind, take care, look after yourselves, and we'll see you in the next one. Cheerio.